have lots of material to cover.
Yeah.
So, and unfortunately, Marie will not be able to attend today. I'll be the moderator for the session. So, good afternoon, everyone. So, I want to introduce officially Dr. Wija Oortwijn. So, I learned how to pronounce. I hope it was fine.
Very well.
So, she's a senior researcher in global HTAi at the Radboud University Medical Centre, an associate professor at Leiden University Medical Centre, that's in Netherlands. She holds a PhD in medicine, based on my assessment, you have a very impressive list of accomplishments. I just want to mention a few. You are the founding member of Dutch Society for HTAi and the International HTAi Society, which many of us are very, very familiar. We call it like HTAi. She is the vice president of HTAi, co-chairing the HTAi ISPOR Good Practice Task Force on deliberative process for HTAi, something that you are going to still discuss today. You are associate editor of the International Journal of Technology Assessment in Healthcare. You have more than 25 years of experience in HTAi with key expertise in health policy, priority setting, policy evaluation, measuring the impact of research and health services research. And today you are going to talk about evidence-informed deliberative processes around the globe, which I think is going to be very interesting for many of us. So welcome, and please, you can start.
Thank you so much. So good afternoon, everybody. So my name is Wija Oortwijn indeed. I'm very pleased to speak to you today about a topic which is close to my heart. I've been working on HTAi for more than 25 years, and the work that I'm going to present today is actually the work that we're currently working on and also implementing in different countries around the globe, and especially in middle-income countries. So the outline of my talk today is about why is there a need for evidence-informed deliberative processes. We call that EDPs, so that's easier for me to pronounce. Also the fundamentals of EDPs, so what are the theoretical frameworks that are underlying EDPs? How did we design EDPs, and I will also talk about best practices and some real-world experiences that we have by implementing these EDPs in different countries. So why is there a need for EDPs? So actually striving for universal healthcare coverage, that's a global issue, right? So all the countries around the globe need to set the priorities because we all have limited resources, also rich countries like Canada and the Netherlands as well. So in talking about priority setting, it's very important to understand which interventions we need to select in terms of funding, but also to deselect. So what do we what could be deselected from the benefit package in order to best allocate the limited resources that we have in order to promote population health. As you probably all know, health technology assessment can aid countries and the governments in making those decisions. So it's very much about aiming to inform decision making. We also do know, and there are ample examples, and especially now around new high-priced drugs, that not everybody believes that the price is in relation to the value of that particular drug. So there are different values at stake when we talk about priority setting. And this is exactly what I'm going to talk about. Indeed, is that in order to make a decision about what to fund and what not to fund, you need to have some understanding about the value of a technology. And of course, HTAi is aimed to do that, but even so, how do you make those decisions, and on the basis of what kind of arguments do you make those decisions? And these can, of course, differ depending on the stakeholder views that you have. For example, if you are a patient, or if you are an industry representative, or if you are a policymaker, you might have different views on what is best value for money. So, and exactly this is why EDPs are so important, because they are aimed to make decisions more legitimate. So that's exactly the point, what I'm trying to bring across today. So EDPs are actually a practical stepwise approach to enhance the legitimate benefit package design. And it's based on deliberation between stakeholders. And there are two fundamental aspects in our approach, and that is the combination of the use of evidence, so use of HTAi evidence, mainly surrounded by the criteria, so multi-criteria decision analysis. So what kind of criteria do you want to take into account when you want to make your benefit package design? But also deliberation. And deliberation is very important here. It's not about stakeholder involvement. It is about the participation of stakeholders or the exchange of views between stakeholders. So that's the difference. So it's not one-way communication or consultation, but it's about deliberation in terms of I have certain arguments why I believe this is very important, and you might have other arguments based on your background theories. And in order to exchange those views, you need to participate in a deliberation. So I think that's very important to understand, because if you look at the literature nowadays and also HTAi practice, most of the practices are focusing on stakeholder consultation, and that is not deliberation. So I think that's a very fundamental point. Like I said, it aims to enhance the legitimacy of the recommendations or decisions made by improving the quality, the consistency, and the transparency of the process. So it's all about the process. So how can an HTAi body or another organization organize their process in order to make legitimate decisions? So this is what we focus on, and it's not new. So we actually use the framework of multi-criteria decision analysis, and deliberation is mainly based on the principles of accountability for reasonableness. So this is also what you see in the core principles that we adhere to. So all relevant values should be taken into account in order to have meaningful stakeholder participation. Transparency is very important. Accountability is very important. Independence of the evidence collection, for example, but also the appraisal needs to be surrounded by independence or based on independence, but also there should be opportunities for appeal. So these are actually the principles reflected in the A4R, the Accountability for Reasonableness framework, but the Accountability for Reasonable framework is not very practical. So what we have tried to do is to translate those in very practical steps in combination with how to use multi-criteria in a decision analysis environment. It's very important to understand that in order to have meaningful stakeholder participation, it's also important that there is sufficient resources available, but also that the process in which you try to deliberate should be cost-effective and timely. So the deliberation should not be a kind of fifth hurdle in order to, for example, get certain technologies reimbursed. So I move on because I think we have questions later on. So please note down your questions, and I'm very happy to answer those after my talk. So the question is how do we organize these EDPs? What is it, and how do we implement those? So based on the principles that I just mentioned, we developed a practical guide, and it's mainly targeting HTAi bodies, but also countries that don't have an HTAi body. So it's not only HTAi bodies, but it is mainly about those that are very much at the center of conducting HTAi or organizing the process around appraisal. And most often HTAi bodies are involved in these processes, so that's why we targeted those. The practical guide is online available. It's free, so you can use it if you want, or you could look at it. And we have applied the guide in different countries, mainly middle-income countries like Indonesia, Iran, Kazakhstan, just finalized, and Ukraine. And we are still working in Pakistan and just started off in Moldova. And the Moldova project, for example, is funded by the World Bank. And we work with the Ministry of Health and the National Health Insurance Fund, because those are the most important organizations. But they don't have any HTAi yet. So there is nothing, I mean, they have some people working in HTAi, but there is not really a structure that we can build upon. In Kazakhstan, there is a HTAi agency. It's a department, not related to the Ministry of Health in terms of within the Ministry of Health, but they had a bit more capacity than, for example, in Moldova. So there's quite some difference in the structures, and I think that's also very important to know that no country is the same, and you really have to understand the decision-making context in order to see where you could enhance deliberation, and especially in countries where there is less democratic environment, it might be also a bit difficult, but it's not impossible. And that's also my personal drive to see if we at least can make the process a bit more transparent and more rational and also more meaningful, because this is public money and the money that I believe needs to be spent in the best possible way. So by our implementing work, we also try to enhance our own work and see where we can improve. And so actually we are just in the final phase of updating the guide based on these real-world experience that we have, but also based on surveys that we did among INATA members, so the International Network of HTAi Agencies, as well as lower middle income experts, not necessarily working for an HTAi body. And I will present about the work that we have done. So the 6 steps that we use in our guide are related to the HTAi process. So in each of the steps, we look where deliberation could take place or should take place, and how that could be organized, whether or not you have already a structure in place or not. So we have structured the guide and also our work when we implement it in the countries along these 6 steps. So first we look if there is a kind of appraisal committee or advisory committee in place. And if not, then we advise to install an advisory committee that can guide the different steps in the process. So that's the first step. So then we also look whether or not a country already has reimbursement criteria in place and whether these need to be defined or redefined. We also look at the process of how technologies are identified for HTAi and how to select those and how to indeed meaningful have stakeholders involved in that process. Then the core is, of course, the HTAi process itself with scoping, assessment, and appraisal. And then we also look at communication and appeal, because that's very important for enhancing the legitimacy. And monitoring and evaluation is mainly about learning. So learning about, okay, if we want to improve our process, how can we then identify the most important indicators and also put that in a system and then re-evaluate that after a certain time. So these are the globally the steps which I will elaborate on now. So this is for your information. We have published about our work. So this is one of the first articles that we wrote more about the theory and the background of EDPs. This article is about the survey results among INATA members, which was published last year. And this is the latest article, also last year, about the use of EDPs in low middle income countries. So what we found by doing these surveys, because we just asked the different HTAi bodies as well as these experts, do you already have a system in place that adheres to the EDP thinking, yes or no? How does that look like? And do you believe, if you don't have such a structure in place, if there is a need for guidance? So do you see the need for deliberation? Do you see the need for EDPs in your own practice? And what we found was that the INATA members, not surprisingly, mainly thought they could improve around the identification and selection of HTAi or technologies for HTAi, the scoping, but also the appraisal and especially the communication and appeal. The low middle income country experts also said that there was a need for guidance around installing an advisory committee, but that's, I think, also very obvious because most of them did not have a HTAi body or a appraisal committee in place. But also they felt that there was also a need to enhance their own HTAi process, so the assessment phase. And I think that's also something that we already know from the literature, that low middle income countries need to improve on their capacity building in terms of assessment. On the right side of the slide here, you see the countries or the flags of the countries that have been noted by the interviewees or the survey respondents as best practices. So for example, when you want to install an advisory committee, the majority of the survey respondents felt that the Canadian Agency for so CADIS or NICE or CONITEC in Brazil could be looked at as inspiration, not as a blueprint, but as inspiration. With regard to defining the decision criteria, Sweden was mentioned. And for a system for identification and selection of HTAi, for example, Spain, but also Canada and the UK were mentioned. So you can see clearly that the Canadian agency, but also the UK, so NICE, but in some cases also the Scottish Medicines Consortium, SMC, as well as PBAC were mentioned. And this is also what we already knew from another study that we did, is that these are often seen as best practices for HTAi practice around the globe, even though all HTAi agencies themselves felt that they could improve. So this is not the best practice, it is a best practice for a certain aspect in place. So because you can also see that not for every step in our guide, for example, NICE or the Canadian agency was mentioned. So even there is improvement to be made. And that's also something we see because NICE is updating their process guidelines for HTAi. The Canadian agency is working on deliberation. Also, CONITEC is working on deliberation in improving that. IQWiC in Germany has just updated their methods guidelines for assessment. And also the French agency has just published a new guideline on appraisal. So it is very topical and very timely to look at these processes. So now I will go quickly because I think I have to be attentive of time, because I want to show you all the 6 steps. So I will start with installing an advisory committee, and especially if you want to install an advisory committee, where to or what is important when you think about deliberative process, what should be considered, and also I will give you an example of how Kazakhstan has done this. So actually for each of the steps, we identified what we call indicators that are felt to be important from a deliberative perspective. So that at least you should take into account. So when you want to install an advisory committee, it's very important that there is a publicly available document that describes the composition, the terms and selection of the members of such a committee, the roles, the responsibilities. For example, what is the role of the chair? Does everybody has voting rights or not? Are different perspectives involved? For example, is there a patient representative or industry or consumer, depending also, of course, on the context of your country, because in some countries industry is not allowed and in other countries industry is allowed. So there is not the best way, but it's something to think about. So this is mainly to let the countries reflect on what they have and what they would like to have. Also the approach followed by the advisory committee. So how is a recommendation being formulated? Is this through a consensus or through majority of voting? Do you allow stakeholders to be involved in the meetings? Is it the meeting closed or open? These are all aspects that you could think about. And indeed, very important, how do you engage and how can stakeholders participate in this process? So this is an overview, and we will have this in the updated guide as well. So you can see the flavor that different HTAi bodies have. So there is no best way, and you can see that the number of committee members range quite a lot. So ZIN, for example, that's the Netherlands, that's our appraisal committee, has 9 committee members that reflect the so-called societal perspective in the Netherlands, while NICE has 4 committees, and each of these committees has 24. So in total there are 69 committee members involved in their appraisal work or in the HTAi work. You could also see who or whether or not public representation is available in these committees. Sometimes both are reflected. So some committees do have both consumers and patients. Some only have consumers, some only have patients. CONITEC, for example, in Brazil, does not have a real consumer representative, but they have a national health committee representative that more or less should be reflective of the consumer voice. But of course, you could highly question that. And this is also something CONITEC wants to work on. And you can also see that the way in which they make their decisions differ. So some of the countries use consensus and some of the countries use majority. So this is just for inspiration and to understand why the appraisal committees or advisory committees work as they do, and also how meaningful stakeholder participation could be taken on. I think it's also very important to understand that the size of the committee could also be of influence on the deliberation itself. So there is literature that suggests that the ideal committee size should be around 15, because everything which is more than 15 seems to be more difficult to come to effective deliberation. So I think it's very important to understand that the balance between effective deliberation and inclusiveness. So this is something that committees need to take into account. So that's why I think it's nice to see the differences. This is the example from Kazakhstan. This is just to show you that we worked with the Ministry of Health, and we felt, based on their decision-making context, that they should have a kind of representation of different viewpoints or values, as you wish. So here you can see what we proposed and also what has been approved by the Ministry of Health. So this is just to give you a flavor of how you could work within a country, and also whether or not the ministry is willing to take over your advice. So this is also something very important. So even the implementation of the deliberative process should be in deliberation with those that work in the country, of course. And we also work with locals in the country itself. With regard to the decision criteria, this is also a very important point, is the reimbursement decision criteria. So it's not about the HTAi assessment criteria, but this is more about what criteria are taken into account when a decision or recommendation is made. So on the basis of what kind of criteria, and of course the HTAi information should be aligned with those criteria, but it's also very important to understand that the decision-making criteria should be aligned with the values of the healthcare system itself. So, for example, if you focus on universal healthcare coverage, it's very apparent that, for example, cost effectiveness could be included, and if not, I think it should be very clear why this is not taken into account. Financial risk protection could be another important criteria. So it's very important to understand what do we want as a society achieve with our healthcare budget, and how does that align with our HTAi process. And this step is often not very clear in almost all countries I've been working or looked at, even not in my own country. So it's very interesting to see how criteria are decided upon and whether or not they are evaluated after a certain time or not. So the health system review, so this health system perspective, is often not seen, or at least not very aligned with the HTAi process. And also, if we talk about societal perspective, and a lot of HTAi bodies take the societal perspective as the perspective in their assessment reports, it's often very interesting to see that the way in which stakeholder views are reflected in these decision criteria or in the HTAi criteria is often not very apparent. So this is also something that what we say you could think about. It's not prescriptive, but it's something that you could think about and make clear to the public, because indeed it's again public money, why certain aspects are not taken into account. So the rationale for your decision, that is very important, because then it becomes also more clear for the public whether or not they could or would agree with certain actions to be taken. So decision criteria, like I said, are often related or reflected in the health system's goal. And of course, equity, solidarity are the underlying values. So this is what we would like to see, but often this is not the case. So, for example, in the Netherlands, so ZIN is on the left side, TLV, that's Sweden. They use different kind of reimbursement criteria. For example, in the Netherlands, we use necessity, effectiveness, cost effectiveness, and what we call feasibility, and I will come back to that. And Sweden, it's human dignity, needs, and solidarity, and cost effectiveness. So here you can already see different kinds of criteria. So Sweden is very much aligned with their health system goals. So you really can see the needs and solidarity, human dignity are the ethical values. While in the Netherlands, it is not completely clear how we came to these criteria. I mean, indirectly, they are related to our health system goals, but there is no policy document in which this is clearly stated. So it's very important to understand also how they are defined, and also that this is still work in progress. In the Netherlands, we are still working on defining our reimbursement criteria. So currently the appraisal committee, or the HTAi body, together with the appraisal committee, are working on how to define this criteria feasibility. What do we mean by that? What kind of aspects could be included, and how could they be considered in the appraisal phase? So how would they impact on the decision? TLV, their criteria definitions are felt not to be always very transparent. For example, with regard to needs, it really depends on the interpretation. This is something that also has been published about. And of course, do they interpret that as unmet medical need or just need? That's something not very clear. So you could see still that countries are struggling also with making their own processes transparent and adhering to indeed the principles of the accountability for reasonableness. So this is something that is very illustrative also for countries that do not yet have a system. So to make very clear that this is not a one-time exercise. This needs to be done periodically, and also the monitoring evaluation there was very important. So if you don't have criteria yet, reimbursement criteria, because there are countries that do not have a a benefit package yet, or they need to redefine their benefit package according to more the accountability for reasonableness criteria. Then what we have learned is best to use a stepwise process. So this is based on the work we have that we have carried out in Iran, Kazakhstan, and Pakistan. So what we normally do is we look at the policy documents that are already in place, so national health strategies or national health insurance fund legal documents, and see, okay, what kind of concepts or values are already mentioned in these legal and policy relevant documents. Then we ask the working group or the advisory committee if they have to group these and think about, okay, how could we easily use these in more defined, transparent way when we want to define the benefit package. So this is the third step. Then ideally, we would like to do a survey with a broad range of stakeholders, if possible. To ask for the preferences of this stakeholder group or the population to identify the most relevant criteria in light of also the health system values, and then discuss these with the working group or with a broad representation of stakeholders to understand what are the most important criteria for you at this moment to define the benefit package. And then that's something that is very important to, we would like to present those again to the public to have scrutiny of these reimbursement decision criteria in order to have legitimacy from the public as well. This is not always possible, but if possible, it would be nice. And then the Ministry of Health or the legal authority needs to approve, and it's best to have it in a policy relevant document. This is something that we did in Kazakhstan. We did not do step 4 because that was not doable in the time that we had available, but at least we extracted the criteria from policy relevant documents, and we discussed it with the appraisal committee, then made them or defined them together, and then we scrutinized them, and then it went to the Ministry of Health, and they use it now for their benefit package. So it is doable, but it takes a long breath. So here you can see the criteria that we use for the in the Kazakhstan project. I will speed up a bit. So in terms of selecting health technologies, this is mainly about the identification and selection of health technologies. It's mainly about adhering to already structured processes that are in place or which we are aware of from the literature. And it's very important to indeed mention or to describe how you involve the stakeholders and also the roles and responsibility of the stakeholders. So this is something I would say it's pretty clear cut. What we do see is that there are different methods to identify and select potential topics for HTAi. So these can be more implicit or more explicit. So there can be ad hoc requests, for example. There can be nomination mechanisms, and there can be horizon scanning systems in place, which are more explicit. And here you can see examples of countries that do have such horizon scanning systems already in place, which are often very explicit about which criteria they use, whether or not they use a stakeholder, mainly consultation, almost never participation. Is very, very interesting. And most of these countries follow standardized procedures from Euroscan. With regard to the nomination mechanism, which we often see in middle-income countries, there is also a difference between closed nomination mechanism, which means there's just a formal request, or targeted, so they are specific stakeholders to select technologies from predefined categories. For example, in Ukraine, the Ministry of Health identifies every year topics or disease areas that are of interest. For example, last year they selected neonatal services, cancer, diabetes, and then they ask working groups to make selection based on criteria, which technology should be selected for HTAi. And there can also be open consultation. Thailand, Germany, for example, use these mechanisms, and these are also published. So it's interesting to look for these articles if you are interested. And I can also share information about that, but most of these is also in our guide, also the reference to this literature. The assessment phase, I think most of you are very familiar with the assessment phase, so I will quickly go over this one. This is mainly for countries that do not have any formal HTAi process in place, so it can help them understand how they could organize these processes, adhering to participation of stakeholders. So again, it's very important that countries describe how they organize the scoping phase, including the meaningful stakeholder participation, and also what the roles and the responsibilities are. So how to do scoping, I think I should not elaborate on that, but I think it's very nice to see that even in the scoping, because scoping, there is not a lot of literature about scoping, that often the way scoping is done is mainly through consultation and not very often through participation. And I think Germany is one of the countries, at least that we've, and I'm forward looking to hear if you know other examples, how stakeholders really participate in the determination, for example, of outcome measures or appropriate comparators. So this is something that I'm very much interested in myself, because the literature base is very poor in that respect. What we also see is that HTAi bodies often do their own scope if they carry out their own HTAi, and if they do not carry out their own HTAi, for example, if they contract universities, the scoping is done by the universities, often in consultation with stakeholders. So assessment, in our guide, we do not elaborate on this either a lot because there are already frameworks in place like the UNETA core model, or for example, agree checklist, or any kind of quality checklist that we refer to. What is interesting, I think, is mainly for the assessment phase is how do HTA bodies or those that conduct HTA involve by participation indeed other stakeholders? Do they collect evidence, for example, through patients, not in terms of research partners, but more like, okay, how do we shape the whole research? But also indeed, if you have an HTA report, is this report then reviewed, but also added to and also debated with HTA doers? And this is something that is most often not done. Most often HTA reports are sent for consultation to stakeholder groups like patients, like industry, like clinicians, to add to the evidence base, but not necessarily debate about the difference of viewpoints or evidence that is missing. So it's more an add-on instead of deliberation about what we have found and how you interpreted the evidence in the HTA report. So here you can see the different HTA bodies that do consultation, not participation, but all of these, I would say, well-established HTA agencies do consultation. This is an example of Germany, where IQWiC also does consultation. Here you can see how the consultation is done, and these are examples that we also present in our practical guide. So this is an example, for example, for low and middle income countries, how they could organize their consultation. Because sometimes consultation is the first step before participation, because that might be more difficult to organize, especially in countries where public involvement or patient involvement is not very much organized yet. Appraisal, I think appraisal is very much discussed in the literature, also by the HTAi Global Policy Forum last year. So it became very apparent that, of course, and it's also, I think, the most known step in HTA where deliberation takes place, because there a formulation of the recommendation has to be made. And of course, our guide is also targeting that, and our guide is also used in the Global Policy Forum background paper as an example, and they also describe different models by different agencies. So this is also about indeed how does the appraisal take place, how are stakeholders indeed involved by means of participation, and also the roles. And I think I mentioned it before, is there indeed a way for different stakeholders to really vote? So are they full members of a committee, or are they just consulted in a meeting, and how does that flow, and why? In the appraisal committee, the use of multi-criteria decision analysis becomes also more apparent. So here at this slide, you can see the criteria on the left side, for example. Oh, sorry, on the left side there are the technologies. This is just a hypothetical example, and the criteria here are cost effectiveness, severity of disease, and disease of the poor, and I can't see the other one because but anyway, so this is just the criteria, and here you can see the evidence that is often collected, so and presented in an HTA report, and often single technology assessments are done. So even often you don't have 4 technologies to choose between, but in this case, I just show you how that could look like. And this is called a performance matrix. So if an appraisal committee needs to make a decision about a certain technology, they need to have explicit information about the reimbursement decision criteria that they have chosen. So in this case, cost effectiveness severity of disease. And of course, the question is, how do you use this information in an appraisal? How do you make a recommendation on the basis of this if there are no clear rules? And this can be done by what we call qualitative MCDA. So you just debate about all of this, and then you might come to a decision. And then, of course, especially the arguments why you believe a certain, criteria is more important than the other, if it's not clear, is very important. You can also use quantitative MCDA that has quite some limitations, or decision rule MCDA. And we have also published about the difference between it. I can't go into too much detail now, but what we do see is that countries more or less often use qualitative MCDA. That's what we see. There are a few countries that use quantitative MCDA, especially countries that have to make a decision among a huge number of technologies. For example, if they are just starting to define their benefit package, then quantitative MCDA might be a quick win because you can't produce, you could produce decision rules, but sometimes it's very easy to, just to make a sifting between those that are very apparent not cost effective and those that are cost effective. That could be an argument, and that has been done, for example, in Colombia when they defined their benefit packets, but now they move more to a qualitative MCDA. And there are also countries that use decision rule MCDA, like the UK, like NICE, and like the Netherlands. And I will give you an example of that. In Kazakhstan, a combination was suggested by the appraisal committee themselves. So they felt that quantitative MCDA was for them more appropriate. And if there is a lot of uncertainty about certain evidence with regard to certain decision criteria, they would like to go to decision rule MCDA. So that could also be an option. So here you can see that the countries that use decision rules, and decision rules, how does that look like? So in the Netherlands, we have these 4 reimbursement criteria. So we have necessity, and we do have effectiveness, cost effectiveness, and feasibility. So the first question that we always ask, or I mean the appraisal committee in the Netherlands is this an effective treatment? Yes or no? So if it's yes, then we it goes to, you could see that on the I don't know, the upper end of the slide. If it is an effective treatment, we also ask what is the burden of disease, and if this is high, medium, or low. You could see in the box on the left side of the slide how we have defined severity of disease. That's through proportional shortfall, and the categories are according to high, medium, or low. And the burden of disease is trade-off in combination with the cost effectiveness threshold that we have. It's not a fixed threshold, but at least it's a kind of threshold. So we use the threshold, cost per quality, in relation to the severity of disease. And of course, if the answer to both is yes or no, even then there could be arguments why the appraisal committee wants to decide not to reimburse or to reimburse. So here you can see I put the pictures of the deliberation. It's not always very apparent, or there might be, like I said, reasons that could be overriding even the decision rules. And how that might look like, or what kind of arguments that our appraisal committee uses on this slide. So, for example, there might be reasons to accept higher or lower cost per quality than the reference value. These are also publicly known. And this is also something that the appraisal committee struggles with, because they feel that they do have the autonomy and also the responsibility to make these decisions on behalf of the public. And they also want to make these arguments publicly known and also use these consistently across different decisions. So it's very, it's from their perspective, but also from the societal perspective, they feel that they can be held accountable if they do not use these criteria consistently over time. That's why they are now working on making a kind of, I would say, reference document, how to use these criteria in their deliberation. So it's very clear for the public when they make a recommendation on the basis of what kind of arguments, and if it is not fitting their decision rule, why they have decided to make another decision than according to the decision rule. And nowadays they are also focusing on adding cost-based arguments, especially around high-priced drugs, because we can't afford all the drugs. So they are also thinking about a new category and how to frame that. That is something that they are currently working on within ZIN, within the HTAi body. Another aspect, I see I have 5 minutes left, so I will very quickly go through this, is whether or not the meetings are open or closed. This is also interesting. So you can see about public scrutiny, but also about legitimacy, that some of the agencies are not open for the public. So this is something that's also interesting. Communication and appeal is something that we would recommend for HTAi bodies to have in place, but most of the countries already have this in place. But those, of course, that do not have an HTAi body need to think about how to organize this, and we give some guidance for that as well. Well, this is just what kind of questions you could ask, and I also already presented that also middle-income countries with an HTAi body do have an appeal procedure in place. And monitoring and evaluation is more general. This is something that we just would like HTAi bodies to consider and also put in place. And this is something that is also not very known yet within HTAi bodies. They sometimes do use reassessment of their decisions, but not always of their processes. Although a lot of countries are just starting with that, like I said before, like NICE is working on their process, the Canadian agency, but also CONITEC. This is also something you could write down in a publicly available document, so it could be scrutinized by the public. Well, my last slide is this. I think several HTAi bodies have already certain elements of EDPs in place, and they can really serve as inspiration for others, not as a blueprint, but more like an inspiration, because it's very much dependent on the context how a deliberative process is or could be organized. So it's very important to understand the context in the first place and never copy anything from one country to another. We also know that there is still a clear need for guidance and principles around deliberative processes, and I refer here to the Global Policy Forum document that is only targeting the appraisal phase. And in the HTAi ISPOR task force, which I'm co-leading, we are also focusing on the other stages of the HTAi process. So, and we are working very hard on the manuscripts. I do hope it will be finished by the end of this year, and hope to give more guidance as well. So this is what I would like to share, and some flowers from the Netherlands. And I'm very looking forward to some questions. Thank you.
Thank you. This is very, very interesting. And you know, in the audience, we have people with international HTAi experience, and we have people who actually work for CADET. I'm sure there will be many questions. I already have one. I think the first was sent while you were presenting from Christopher Longo. He's asking, can you discuss the benefits, risks of majority versus consensus for decisions?
Yeah, well, I think it's not, there is no, that's a very good question. I think it's very difficult to say what is better. And so it really depends on the context. If some countries, I mean, like the Netherlands, we are a consensus-driven country. So for us, it's very clear it should be consensus. But I think it's more about how the deliberation took place and on the basis of what kind of arguments the recommendation is made. So even it could be consensus, but if it's not clear on the basis of what arguments the different stakeholders or the appraisal committee members have given their consensus to the consensus outcome, I think it's very difficult to understand for the public. So if you have majority, it could be more explicit, but it also depends if the arguments are not known. So I think there are both pros and cons for both of the mechanisms. I think there is never a one way answer.
There's no right, yeah.
Yes. I hope that clarifies.
I hear, I see in the chat and in the question box, people are thanking you for this interesting presentation. And one of the attendees, Kristen McMartin, mentions that the process you described is similar to what we have at OTAG, like it's Ontario Health Technology Advisory Committee, which I think, as you know, like we have CADA that kind of makes recommendation, but then each province makes it on. This for Ontario. So we have a question from Dominika Ranik. I'm interested in knowing what happens in step 1 of the decision rules in the Netherlands when the question is this effective cannot be answered unambiguously. For example, the evidence is weak or inconclusive. Mm-hmm. What happens?
Yeah, well, that's also a very good question. So we do have a what we call a scientific advisory council, and they prepare actually the work for the appraisal committee. So if the evidence is not ambiguous, they would present it, or first of all, they try to make it very clear that it is not ambiguous. And if it's not conclusive, then we will not reimburse. That's our knockout. We call it knockout criterion. So, but sometimes, of course, it could be cost effective, and so sometimes there might be different pathways. But if it's clearly not effective, then it will not be reimbursed.
Yeah, I guess the question is most like sometimes, it's just uncertain, right? Just, wide confidence intervals, small, like, I guess. Yeah. I don't see any other questions coming.
But I think indeed that's a very good question. And that's also something that a lot of HTAi bodies struggle with, indeed, how to address the uncertainty in the HTAi, already in the HTAi. And of course, that's also why it's very important to debate about the uncertainty of especially the clinical evidence, but also the cost effectiveness, because also a lot of uncertainty could happen there. And that's also a topic that is going to be discussed by the Global Policy Forum next week, this uncertainty, how to deal with this, and how does that impact indeed also the deliberation. For those that are interested in this, there is a European project, it's called IMPACT, and that is especially dealing with uncertainty around rare diseases. And they also organize webinars on this, and they are in the final phase of publishing their reports.
Like with rare disease always. I think that years ago there was this debate whether scarcity or rarity should be weighted differently. Like it's a separate conversation. I don't see any other comments. The slides will be available. I just have one more last question, and I think we'll let you go.
Sure.
I'm from Armenia, so I'm from one of the post-Soviet countries. And I remember my first few years at THETA, I was thinking, oh God, we never have anything like this in Armenia. There's no way we can have anything like this. And then it's funny, you mentioned Moldova, Ukraine, Kazakhstan. These are all post-Soviet countries where all the decisions are very hierarchical.
Yeah.
And there are different reasons why certain devices and drugs will end up on the list, on formula, totally different reasons. So maybe I just want to ask from your, I guess, first of all, is there a hope for these countries? And the second of all, like, what's the most common difficulty you faced when you were thinking about implementing a process like this?
Yeah, it is a very good question. And there is hope. Because when you look at Ukraine, I think Ukraine, but also if you look at Brazil, you know, when, of course, when they started, they were also, you know, at the very beginning. But in Ukraine, I think they really made very good steps. And I think the most important issue is political will. So you need to have people in the ministry. You need to have at least a few advocates for HTAi, for using evidence in policy making, but also that really are interested in driving this. And capacity, of course, that's another thing. You need to have capacity on the ground to do the HTAs, because that's also something in what we see also in Moldova. I mean, it's a very small country. And there is very little capacity. And if there's capacity, they move out the country, like yourself.
Yeah, I you know, you brought that again, like, I think you have to finish, but I noticed when you published this, along the publication of this manuscript, there were many like opinion papers along with this. I've never seen it. And then one of the authors mentioned that, you know, oftentimes we bring these people, we train them, and then they leave the country. There was exactly this conversation. I agree with that. So, but well, very interesting.
Yeah, I think one of the most important things that I really would like to also emphasize is invest in education. So educational programs at the university, at the medical universities, and indeed countries, in the new countries, I think it's very important. So you can also train people, you know, you can train students, not only postgraduate, so they go to indeed, you know, countries like, you know, Canada, the Netherlands, UK, and they stay there. No, just, you know, train them already in their master programs. And that's something I really believe in. And I think it's also very important that we as HTAi, for example, should organize more regional meetings with people on the ground to really show them what the added value of HTAi can be for their countries, because it also is meant to be, you know, to make to improve the population health, right? It's not about cost containment. That is also something, but it's also about improving the health of the population and to have a better spending of the public money. But you really have to have a long breath.
Yeah, and political willingness, I think that's, like, as you mentioned, like one of the drivers, right? So there is a will, there is a way, usually.
Yeah, certainly.
Apologies, very briefly before you go, we have one question again from Dominica. She's asking if it's possible to follow up with you via email if somebody wishes to get in touch to continue the discussion, how they go about that.
Yeah, no problem. You can, you can share my email, and I also put it on the last slide of my presentation. But I'm happy to follow up with via email or Zoom, whatever people.
Very interesting topic. Very. And
thanks so much.
Thank you for this work also. Like, you know, I think it's an important work. It's not, things are not localized in, you know, certain countries, but there's a real outreach, basically.
Yeah, absolutely. And that's also something that I personally am very enthusiastic about, you know, working with people in the countries. So to build also their capacity. So it's not me or my colleagues from the Netherlands telling them what to do, but we really try to train them and ask the questions themselves to their Minister of Health, or, you know, I'm very proud, you know, I trained a person two persons from Kazakhstan in 2015. And it paid off by having this project funded by the World Bank, and it's going very slowly, but at least, you know, they really believe in it, and they are now also trying to find funding for indeed the medical universities to start master programs in HTAi. And for me, that's something that is very rewarding. So yeah, so that's my personal drive, is to really teach and help support, develop the capacity on the ground, because that's very important. Yeah.
Thank you so much. I think that, yeah, I totally agree with your words, and I'm happy these things are happening. You know, really, really happy for these countries also.
Well, thank you for your kindness, and I'm really happy to share my my experience, my views, and please follow up if you want.
Thank you so much. Thank you. And I think we stayed like over time, but you know.
No, it's perfectly fine. I'm
sure you'll hear from people by email. So.
Yeah, perfectly fine. Thank you so much, and take care.
Thank you. You too.
Bye.